So with that, again, it is my pleasure to welcome everybody to our first of two webinars on head and neck. And tonight we're going to be talking specifically about the facial nerve. We're very fortunate to have Dr. Christina Yver with us, as well as Dr. Matthew Spector, both from the University of Pittsburgh Medical Center. And it is my pleasure to introduce tonight's moderator, Dr. Matthew Spector, who is a head and neck surgeon at the University of Pittsburgh Medical Center. He completed his medical school training at the Stritch School of Medicine at Loyola University in Chicago. He then went on to complete his residency and fellowship in head and neck surgery and microvascular reconstruction. He served as a faculty member at the University of Michigan for 10 years as the director of head and neck oncology program and associate director of head and neck surgical oncology and microvascular reconstruction fellowship. He specializes in all aspects of head and neck surgery, especially the oncology and in head and neck reconstruction. And his research interests relate to both clinical and translational questions in head and neck oncology and head and neck reconstruction. And even as a former Buckeye, and I know Dr. Spector spent many years at University of Michigan, we are honored to have him here tonight and really appreciate him serving as moderator. And with that, I will turn it over to you.
Thank you very much. That's probably the nicest introduction I could get from a Buckeye, so that actually means a lot. Thank you for everybody for joining. I see a lot of familiar faces or names in the attendance, and so looking forward to chatting over the next hour and moderating the panel. I have the pleasure of introducing Dr. Yver tonight. Dr. Yver did her medical school and residency at the University of Pennsylvania. She then did a facial plastics fellowship, and so a year after your residency, she then spent another year, learning more skills on facial nerve reconstruction, facial reanimation, and so she's pretty much the perfect speaker for this tonight. She's now the director of our facial nerve program at the University of Pittsburgh. She's the soon-to-be division chief of our facial plastics division, so we'll be hiring more surgeons under her tutelage. And I'm looking forward to hearing her tonight speak about the facial nerve and where we're going and what we're looking for. So Christina, take it away.
Excellent. Dr. Spector, thank you for that very kind introduction. It's an absolute pleasure to speak to you all tonight. And I'd like to give another thanks to Stephen and the Global Nerve Foundation for inviting me to speak about a topic that's very near and dear to my heart. So without further ado, let me see if I can share my screen here. There. Great. So I have the privilege of speaking about the facial nerve disorders, and by association, facial paralysis. Again, it's a topic that's very near and dear to my heart. It makes up a huge portion of my clinical practice and also the bulk of my kind of academic and research interests. Before I get started, I have no relevant financial disclosures related to this topic. And this is a very visual talk, and it includes a lot of patient photographs and patient videos and surgical videos. So all identifiable photographs have been provided with patient consent. These patients signed, forms of it, basically said they're okay with me sharing their images for teaching purposes, which is much appreciated. So a brief overview of what I'm going to be speaking about today. I'm going to give you all an introduction to facial nerve disorders and a brief discussion of what the facial nerve is. And I want to speak a little bit about the two major subcategories of facial paralysis, because the treatment paradigm is very different, and it's really important to have a differentiation between the two. I'm going to start with a discussion of flaccid facial paralysis, and then halfway through the talk, we'll shift and speak a little bit about facial synkinesis, which is a distinct entity and a distinct subcategory of facial paralysis. And I'll conclude by speaking a bit about some of the progress we've made in these fields, as well as some of the many ongoing challenges we face. So starting with our introduction. The facial nerve is a cranial nerve. What this means that the nerve exits directly from the brainstem, so it doesn't come out of the spinal cord. There's actually 12 cranial nerves in total, and the facial nerve happens to be the 7th one. It comes directly out of the brainstem, and then it has a very complex anatomy where it travels through this narrow bony canal in the mastoid bone, which is this bone you can actually feel right behind your ear. After it travels through that canal, it exits the skull base right at the base of the ear before it sends out this very fine network of branches all over the face to innervate all of the muscles of facial expression. So it's like a giant web of nerve fibers that innervate the facial muscles. So as you would expect, it provides motor innervation to all the muscles that control facial expression. It allows you to raise your eyebrows, close your eyes, smile, make funny faces. It also has some other kind of unique functions that are worth mentioning. It provides a taste sensation to the front of the tongue. It dampens loud sounds and also affects your ability to form tears. So shifting to facial nerve disorders, which is obviously what happens when you have a pathology of the facial nerve. We'll start with a discussion of flaccid facial paralysis, which is a form of facial paralysis that I think most people think of when they think of facial paralysis. So I wanted to briefly discuss two patients who I've met through my practice in the last year who are affected by flaccid facial paralysis, both on the left side. This first woman is absolutely delightful. She developed a facial paralysis on the left side after she had underwent a surgical removal of a brain tumor. And she is a grandmother of 6, and she had told me the thing that bothers her most is that, when her grandkids come over for dinners and holidays, her youngest grandchild has kind of was perturbed or scared of her facial function when he first saw her after the surgery. And that obviously, had a really profound effect on her. And this other gentleman is the kindest gentleman. He developed a facial paralysis after removal of a head and neck tumor of the salivary gland. And he told me that he had plans to go to his 50th college reunion, but ended up canceling because he didn't feel comfortable interacting with his old classmates and acquaintances given his facial paralysis. So this is what flaccid facial paralysis looks like. So let's dig a little bit deeper into kind of what this looks like. And this is a gentleman who saw me a few months back because he developed acute flaccid paralysis after an episode of Bell's palsy, which is the most common cause of flaccid facial paralysis. So if you look at him, this is a standard facial nerve series. So we take these photographs for everyone who comes in the office. And if you look at him, even at rest, he looks a little asymmetric. Like he looks like he has a facial droop on that left side. And it becomes more pronounced as you ask him to make some expressions. So he can't raise his left eyebrow. And when I ask him to close his eyes, he can't close his left eye. He can't smile. He can't pull up the corner of his mouth on that left side. His lower lip is asymmetric. And then on that last photo at the bottom right, you can see that when I ask him to say ooh, his lips pull to the stronger side of the face. That's a key kind of feature of the physical exam. So his lips are pulling over to the right side, the stronger side, and away from his weak side. And this is a classic exam for flaccid facial paralysis. As you can imagine, this can be very debilitating, and they've done quality of life studies to quantify this. And what we found is that up to 60% of patients with this type of paralysis meet clinical criteria for depression and/or anxiety. Several studies have actually quantified that the casual observer who interacts with the facial paralysis patient subconsciously perceives them as less trustworthy and less intelligent and less kind than their peers. And this can often translate into what we call kind of a negative feedback loop, where an observer treats the facial paralysis patient differently, even if it's subconscious, and then the patient perceives this, reacts accordingly, and kind of withdraws from the social interaction. And this can translate into feelings of social isolation and interfere with their ability to socialize. And an elegant study that was published in JAMA tried to quantify kind of these various states of disability and found that people ranked having a facial paralysis as even worse or more undesirable than being blind in one eye. So it's a real problem for these patients. There are many causes of facial paralysis, and I couldn't possibly have an in-depth discussion of all of them, but I wanted to touch on just the vast differential here because diagnosis is actually a huge part of my job when I see a facial paralysis patient. Far and away, the most common etiologies are these viral reactivation syndromes. I'll say a few more words about them in a moment, but this encompasses like a Bell's palsy, or if you are familiar with like a Ramsay-Hunt syndrome or pregnancy-associated Bell's palsy. But it's not all that. We also have to rule out an infectious etiology. So Lyme disease is a common one, especially here in Pittsburgh, unfortunately. HIV, ear infections can also do that. Unfortunately, some facial paralysis is related to tumors, whether they're benign or malignant tumors that invade the facial nerve. We also have to consider inflammatory conditions like, lupus-like syndromes, vasculitis, sarcoidosis, things that can cause inflammation of the nerves of the body. Anything that causes trauma to the facial nerve can obviously cause a facial paralysis. So fractures of this mastoid bone that I mentioned. Unfortunately, I've seen stab wounds where the facial nerve was cut, bad motor vehicle accidents, things like that. And unfortunately, more than we would like to see, we can see facial paralysis from iatrogenic causes, which means it happened as a result of surgery, perhaps unintentionally. So TMJ surgery does put the facial nerve at some risk. Facelift procedure in rare cases can also put the facial nerve at risk. And of course, surgical removal of certain kind of like brain tumors, especially tumors that are in the vicinity of the facial nerve, can result in facial paralysis. Finally, there are some congenital conditions where a baby's actually born with facial paralysis. There are many, and the most common is a condition called Mobius syndrome. So I've seen all of these in my practice. A few extra words about the viral reactivation facial paralysis causes, only because these are far and away the most common. Together, Bell's palsy and Ramsay-Hunt syndrome account for about 70% of all the acute facial paralysis, at least that I see in my clinic. They tend to follow a very classic trajectory. So generally, a patient will develop an acute onset facial droop within about 24 hours. So it's sudden and it's complete. Ramsay-Hunt syndrome is a little different from Bell's palsy in that another cranial nerve 8, is typically involved. So in addition to the facial droop, they'll often complain of hearing loss, sometimes vertigo, and then sometimes they'll develop a rash because Ramsay-Hunt syndrome is actually a kind of a subcategory of shingles. The rash isn't necessary for the diagnosis, but it is commonly seen. But both Bell's palsy and Ramsay-Hunt syndrome are both treated fairly similarly. We typically start these patients on steroids and antivirals as soon as the diagnosis is made and after a stroke is ruled out. The key here is that these patients always recover function. The timing can be variable. It can be 2 weeks, it can be 3 or 4 months. But as long as the diagnosis is correct, eventually the facial function will come back. And if it doesn't come back, then chances are you have the diagnosis wrong. And why is that important? Because I worry sometimes we fall into a trap of diagnosing all facial nerve disorders as a Bell's palsy. And this is why the diagnosis itself is so key. I met this wonderful woman as part of my practice. She had developed a very subtle lower lip weakness that had developed over the course of several weeks and had seen 1 or 2 other providers who advised her this is probably kind of a unique presentation of a Bell's palsy. But as I described, this is not the natural progression of a Bell's palsy. This is a very unique presentation and it does not fit with that diagnosis. So as part of her workup, I ordered an MRI scan, which sure enough did demonstrate a small but aggressive neoplasm of her salivary gland that was starting to invade the facial nerve. And thanks to this, we were able to catch it, remove it, and treat her appropriately, and she's doing very well. So again, you have to kind of maintain a very high index of suspicion for these other things that can cause facial paralysis that aren't just a Bell's palsy. So let's shift gears a little bit, and I'll talk a little bit about the current treatment paradigm for flaccid facial paralysis. These patients who fall under the Bell's palsy umbrella, typically because we know their function is going to get better on its own, it's often very appropriate to just monitor them closely for improvement and let kind of time cure the issue. But if the etiology of the facial paralysis is such that we don't expect function to return on its own, then we start talking about more permanent treatments to treat the facial paralysis. And so that's what I'm going to delve into now. So this can really be divided into 3 major subcategories. One is treatment of the eye, because these patients, as you noticed in the photographs, they don't close their eye all the way. And this can put them at really high risk for corneal complications. Their eye dries out, and they're at risk for corneal ulceration and can even have permanent vision loss. So we like to address the eye. And then we talk about static treatments, which are oftentimes surgical treatments with the goal of making the face appear more symmetric at rest. So they're not walking around with a visible facial droop. And then finally, we consider dynamic treatments when indicated. And these are treatments that are aimed to restore movement, volitional movement, ability to smile and animate the face. And so I'll dive a little bit into each of these now. Starting with treatment of the eye, the eyebrow, and the upper eyelid. Again, the goal is to prioritize corneal protection and lubrication and prevent any long-term vision damage. I will very frequently refer these patients to an ophthalmologist if I have any concern at all about the eye. Ophthalmologists can help to monitor the health of the eye with serial slit lamp exams and help intervene when necessary. I always counsel these patients about the importance of keeping their eye lubricated. So lots of artificial tears all throughout the day, keep things moist. At night, I'll have them use a little gel to their eye, sometimes even tape their eye shut so it doesn't accidentally open while they sleep, and wear glasses to protect them when they're out and about. There are other interventions that I offer through my clinic that can help temporize things or treat kind of permanent issues with the eye. And one of these things is placement of a very small weight that actually goes in a pocket in the upper eyelid. And the idea behind this is that you place this in the clinic, it takes about 20 minutes, and then this allows gravity to help pull down the eyelid when the patient isn't actively keeping their eye open, and helps to protect the eyeball so that they're not, even when they close their eye, they don't have their eye partially open. And this is on the right, kind of an example of how placement of this very small, low profile eyelid weight can help achieve full eye closure. Other patients with facial paralysis, especially older patients, become symptomatic from the sagging of the lower eyelid, and that's called a paralytic ectropion. And sometimes it's mainly a cosmetic problem. They just don't like how their eyelid's sagging down, but it can be functional as well. That can keep them from closing their eye all the way. So there's another minor procedure that again can be done either with the patient awake in the clinic or in the operating room. And it's a lower lid tightening procedure where you basically just kind of mobilize the lower eyelid and tighten it so that their eyelid isn't sagging so much. Finally, unfortunately, I don't have a picture for this on the slide, but brow lifting can be very helpful because some patients with facial paralysis have their eyebrow that just sags down so low that not only is it a cosmetic problem, but it's also a functional problem because their eyelid skin is like hanging in their eye and they're like shedding, dead skin cells into their eye. And so if we just lift that up and clean things up, it can do a lot to improve their ocular hygiene. So that's another very easy thing to address for this patient population. So let's move on to some static suspension techniques. There are numerous ways to do this, but I think the most effective way is by using several bands of fascia lata. And fascia lata is basically just a big strip of fascia that I borrow from the outside of the thigh. So it is a procedure that requires a trip to the operating room. I basically borrow a big swath of fascia lata and I fashion it into several strips to help kind of hoist the face up almost like a seatbelt. And these strips of fascia are inset into several ways. Typically, a very wide band of the fascia lata is used to reconstruct the nasolabial fold, which is this fold in the crease of the cheek. As you can see in this gentleman in the bottom right, the nasolabial fold is often effaced or flat in facial paralysis. And so we can use fascia lata to recreate that fold. And then we use smaller strips of the fascia lata to open up the side of the nose, lift up the corner of the mouth, balance the lower lip, and help to pull the philtrum back into midline. And so this basically just helps patients kind of look a little bit more symmetric when they're out and about. They're making a trip to the grocery store. They don't have the sequela of the facial droop that people classically associate with like a stroke. Not all patients, require this trip to the operating room for a more extensive static suspension. There are less invasive alternatives. That might be a good idea, a good option for patients who maybe can't tolerate a trip to the operating room. So in some cases, you can use actually permanent sutures to pass kind of through the face as kind of a quick static suspension, and that can even be done in the office. So it's a less invasive alternative. Another nice adjunct to these techniques is an asymmetric facelift. So it's not that different from a cosmetic facelift, but the idea is that you do it in an asymmetric way or just on the one side of the facial paralysis to help lift up all the soft tissue that descends with facial paralysis and give people a bit more balance at rest. So these are all great options. Okay, so shifting now to some dynamic reinnervation techniques. Really the workhorse of dynamic reinnervation is nerve transfers. And if I'm going to really boil it down, the idea here is that we want to try to restore volitional movement to a patient with facial paralysis who is not getting any input from their facial nerve. So instead, we borrow nerve input from other adjacent nerves and route those nerve fibers into the distal facial nerve branches and the facial muscles as an alternative source of neural input. There are various types of nerve transfers. I'll give a few highlights. One key point here is this, there have been several really nice anatomic studies that have demonstrated that this really has to be done within about 24 months of the initial denervation. After about the 2-year mark, for whatever reason, the facial muscles are just not receptive to reinnervation, and these nerve transfers don't work. So although it's not an emergency, time is of the essence to get a good result if you're considering dynamic reinnervation. I'll say a few words about one of my favorites, which is a 5 to 7 nerve transfer. The idea here is we take advantage of a nerve called the masseteric nerve. This is a nerve that actually comes from cranial nerve 5, not 7, hence the 5 to 7 nerve transfer. It's a nerve that allows you to chew and kind of bite down and activates these muscles of chewing. And what we found is we can take a branch of this nerve and cut it and reroute it to the facial nerve. In particular, we choose a branch of the facial nerve that controls the smile. So we hook up these two nerves to each other, and so now you have an alternative source of nerve fibers going to the smile muscles. And it does take a few months for these nerves to reroute after the procedure. But once it kicks in, what you have is this really nice, natural-looking, dynamic, bite-driven smile. So you get the smile back, but the patient does have to initially bite down to activate the smile. I refer the patients to physical therapy, and they kind of work on that and it almost becomes second nature. And it can be performed at the same time if there's a facial nerve sacrifice for cancer or resection or repair, but it can also happen in a delayed fashion as long as you try to get it within 24 months. So this is a nice example of a kind of early emerging 5 to 7 nerve transfer smile for a patient of mine who had facial paralysis after a brain tumor resection. So as you may have kind of picked up on, that 5 to 7, it's very reliable, but one drawback is that the patient does have to bite down to smile, which is not the most natural thing. And so I have patients who ask me, well, doc, like, what are the options for a spontaneous smile? Isn't there a way I can smile again without even having to think about it? And so that brings me to the idea of cross-facial nerve grafting, which is another dynamic reinnervation technique. And here the idea is that we use donor nerve fibers from the facial nerve, but on the other side of the face, the side of the face that's not paralyzed. So we pick a branch of that nerve and we route these nerve fibers all the way across the face using a nerve graft that's typically borrowed from the lower leg. And the advantage here is that, when successful, you can get a nice smile from this, and it's oftentimes spontaneous because whenever you're smiling on one side, you're going to be smiling on the other side. But I will say, given the long distance that this nerve has to regenerate, it's not as reliable as the 5 to 7 nerve transfer. So there are pros and cons to each. Anecdotally, we've had good success using this technique to power a muscle graft that helps to recreate the smile called a gracilis flap, which I will talk a little bit about in the next slide. There's also value to this to augment the smile in patients who just have a weak smile from partial facial paralysis and balancing the lower lip and some other kind of adjuncts. So again, this pros and cons to many of these approaches, but this is just a nice technique to have and to discuss with patients looking for options. So I'll finish up my discussion of flaccid paralysis treatment by saying a few words about this free muscle transplant that I refer to. We call this a gracilis free flap. And this is the gold standard for dynamic reinnervation for patients with longstanding flaccid facial paralysis outside of the 24-month window. So they're no longer, unfortunately, a candidate for a nerve transfer. What we do is we harvest a small slip of the gracilis muscle, which is a muscle of the inner thigh, and we transplant it up into the face and inset it in the same orientation as the muscles that let you smile naturally. We then have to hook it up to an artery and a vein in the face, or otherwise it won't survive. And we have to hook it up to a nerve because you can't get dynamic movement of a muscle unless there's a nerve that's activating it. And so this nerve can be the cross-facial nerve graft, or it can be the masseteric nerve, or other combination of nerves. There's really a lot of kind of art to deciding exactly how to inset this muscle and how to power it with these various nerve options. So I will take a quick pause and use this opportunity to shift gears a little bit and speak about treatment of facial synkinesis, which again is almost a completely different entity from flaccid facial paralysis. And there tend to be, it tends to actually be a much larger part of my practice because there are more people who suffer from facial synkinesis than flaccid facial paralysis. But what is synkinesis? So let's go back to this gentleman that I saw before. When he initially saw me, he had just developed Bell's palsy and he had flaccid paralysis on this left side. But given that we felt confident of the diagnosis, I made sure he was treated appropriately, and I saw him back 6 months later. And you'll see his exam has changed. Now, at first glance, you could say, hey, he didn't recover all the way. But if you really start to look at his photos, you'll see that his facial function is now working in a very different way. So at rest, he's much more balanced. He almost looks normal at rest. He doesn't have a left-sided facial droop anymore. But as he starts to activate his face, you still notice he's asymmetric, but in different ways. So now his eye isn't wide open anymore. If anything, it's a little bit too narrow on that left side. He's not smiling well, but it's almost like he's more frozen on that side. And then when he goes to say, ooh, now the mouth is pulling to the left side, not the right side. So something has shifted here. So facial synkinesis has a different exam. Usually the patient's more balanced at rest than the flaccid patient, but they have issues when they start to move their face. They can have brow asymmetry. Fortunately, they're usually able to close their eye all the way, so the eye problems aren't so problematic. But then when they go to start to smile, they feel like they're really tight in the mid-face. They're not able to lift the corner of their mouth correctly. In fact, they feel like the corner of their mouth is dragging down. They often have lower lip asymmetry. They have tightness and pulling in the neck. They can have chin dimpling. When they go ooh, again, their lips are pulling to the affected side now. And one patient described it to me as they said, Doc, I feel like I have a constant Charlie horse of my face. Like I have constant muscle cramps and I can't move my face correctly. So what's going on here? I liken facial synkinesis to a traffic jam. It's a traffic jam of nerve fibers. And what happened is when the patient initially had an insult to the facial nerve, the initial Bell's palsy or whatever it was, those nerve fibers temporarily died off and they were flaccid. They had no movement. But as long as the nerve is anatomically intact, eventually when the inflammation goes down, those nerve fibers start to regenerate. And it takes a while, but they do regenerate. But because the facial nerve has such a complex anatomy, you can imagine a situation where instead of the nerve regenerating in this nice, fine, organized way, it kind of regenerates as a chaotic mess. The nerve fibers get their signals crossed. The one nerve fiber that was supposed to grow up to the eye grows down to the mouth and vice versa. And you just end up with a traffic jam and you're just not able to move the face in the way that you used to be able to move it. So it happens after a transient facial nerve injury, typically characterized by muscle tightness, asymmetry of facial movements, uncoordinated facial movements, and inability to make normal facial expressions. Again, a frozen face phenomenon. I make a big point of talking to patients about this because some of them are incorrectly told that what happened is they didn't recover from their Bell's palsy or they had incomplete nerve recovery. And I think that's a little misleading because unfortunately their nerve did recover. It just recovered in a disorganized way. So I would describe synkinesis as aberrant nerve recovery, not incomplete recovery. So the treatment of synkinesis, unfortunately, I think describing to patients how this happened helps them understand kind of the prognosis, because once synkinesis sets in, unlike the flaccid state, you can't just wait for it to go away. You know, it's how the nerve has regenerated. And so once it sets in, it does tend to be kind of a long-term, permanent issue. But the good news is that it's a treatable condition. There's no magic pill or magic surgery that cures the synkinesis. But we do talk a lot about the synkinesis treatment ladder. And the idea is that we layer on various interventions and therapies until the patient, feels comfortable with how their face is functioning and is no longer asymptomatic from these issues. So physical therapy is a mainstay of, my practice for facial synkinesis patients. And ideally, it's performed by a licensed physical therapist with specialized training in facial nerve disorders. They'll meet with the therapist typically on a weekly or biweekly basis, and they'll work on patient education, soft tissue mobilization, and massage techniques because, again, these muscles are too tight. It's a Charlie horse of the face. They'll work on functional retraining, and then like neuromuscular retraining and facial expression training. And then finally, management of the synkinesis, which is when the face moves in ways that the patient does not intend for it to move. And once they're plugged into physical therapy, then I get to jump in with some interventions of my own. And one of the mainstays of my synkinesis treatment is regular Botox therapy for these patients. It's the same type of Botox that you would get if you went to a med spa, to treat your wrinkles, but I administer it in a completely different way because this is medicinal Botox. It's FDA approved for this indication, so we put it through insurance. Botox lasts about 3 to 4 months, so these patients do see me on a regular basis several times a year for Botox administration. And I administer it strategically to help balance the face, address where they have muscle spasm and pulling and tightness. We also use it to address functional issues such as trouble speaking or drooling. It's really good for certain things, like with synkinesis, the eye is often too narrow and squinty, and so we can use Botox to open up the eye and make it more symmetric. And so every patient's Botox treatment pattern is a little bit different, but it is kind of a good first-line therapy for these patients. I counsel my patients that, Botox is really good for some things and not for other things. So I have kind of adjunct treatments that I offer them as well. And one of selective myectomy is also a nice adjunct to Botox. Selective myectomy just means we are targeting and snipping specific muscles of the face that are contributing to the synkinesis problem. The most common myectomy that I perform in my practice is something that I've kind of coined a smile release procedure. The technical name for it is a depressor anguli oris resection. And this muscle, the depressor anguli oris, also known as the DAO muscle, is a small fan-shaped muscle that pulls down on the lower corner of the lip. And so it kind of, when people smile, their corner of their lip is tethered downward, making it look like they're grimacing, which obviously they don't like. So the idea is that we can do about a 20-minute office procedure where we access this muscle through a small incision on the inside of the cheek, and then we snip that muscle and close it up with a few dissolving sutures. It's covered by insurance. It's done in a clinic setting, so there's no need for general anesthesia. And it's overall very safe and well tolerated. And the idea is that you get a little release to the corner of the mouth so that the smile is more balanced and you don't have such a downward drag on the corner of the mouth. This is the issue with the smile is something that Botox is not as effective for. So I very frequently will have patients start on a regimen of Botox and then also concurrently schedule this DAO procedure. And together, these things can be very effective for managing mild synkinesis. So for these patients who kind of engage in these first-line treatments and are not quite making the progress that they want to make, we talk about kind of the next step on the ladder. And a really nice option for some of these patients is a procedure that requires a trip to the operating room. It's called a selective neurectomy. And when I describe this procedure to patients, I describe it as a procedure aimed at getting to the root of the problem, which is this aberrant regeneration of the facial nerve. So with the patient asleep under anesthesia, a facelift incision is made. So it is an external incision, but it's a very cosmetic one. And this allows me to access all the distal branches of the facial nerve. And I'll typically find up to 10 to 12 branches. And I will use a nerve stimulator to stimulate each one of them. And I'll keep the good ones and I will snip the bad ones. And so this can be very effective for addressing some of the tightness and the pulling of the face, especially the lower face, and also releasing the smile so that you get more pull up on the corners of the mouth and better dental display. As you can see with this woman, this is her before picture. And then this is 8 weeks after a selective neurectomy with a little bit of Botox to help address the left eye. So this can be a really powerful tool for patients who are looking for a more dramatic improvement. So the selective neurectomy, there is an art to doing this procedure. You may ask, how do you even decide which ones to cut and which ones to keep? And I would say that the procedure does have to be tailored to the patient's exam. So this patient here had presented to me with severe right-sided synkinesis. And you can see she's really tight around her eye, but in her midface especially, she's got this really deep, pronounced nasolabial fold. And it's almost like her upper lip is like kind of pulled up and retracted into the midface. So when she goes to smile, it almost looks a little bit more kind of like a snarl type of thing. This is kind of an example of what this might look like in the operation. So I'm going to just skip that first. So we're taking, so this is a big branch. You see that big branch that's pulling that snarl? I knew that was a problem for her. And so we took that branch. We're keeping. That's a more gentle smile branch. So I wanted to preserve an ability to smile for her. So we keep that branch. We're taking. We're taking. So I'm marching down the face and I'm identifying good versus bad. That one is a little pull down at the corner. I don't want to pull down. So we take that one and we take a bunch of lower facial branches that give that down. You're taking. Another one that's pulling down on the corner. So we don't want that one. We are taking. This is the part where I find almost, I think, 7 branches or so. We are taking. We are taking. We are keeping. So I always try to preserve a branch that depresses the lower lip because that's the lower lip asymmetry is always problematic in synkinesis, and we want to preserve that. So I basically am preserving branches that do nice smile and lower lip function and getting rid of all those branches that cause the tightness in the midface and the drag down on the corner of the mouth. And sure enough, this is her pre-op photos compared to her being 4 months post-op. You can appreciate that at rest, she looks so much more balanced. She still has some tightness around the eye, which is not unusual after this procedure. But look at this kind of improvement in balance in her smile, right? She now has kind of balanced smile, but we preserved her ability to smile while getting rid of this kind of snarly mid-face activation. She has beautiful lower lip function. And when you have her go, ooh, you can see that her face is much more balanced in terms of its tones. So the lips are no longer pulling so dramatically over to the synkinetic side. All right, so I'm just about out of time. I'll breeze through this very last part as a conclusion to my talk. I think we have to always ask ourselves as clinicians, how can we be doing better? And this is especially relevant in facial nerve care and facial plastic surgery, because I think it's easy for any of us to show, as I did today, a bunch of photos and videos of our most successful cases and say, look, I'm doing such a great job. But without true data, it's hard to know if we're really moving the needle on a larger scale. And, unfortunately, cancer doctors and cancer surgeons like Dr. Spector have that data a little bit more available. They can tell you their recurrence rates. They get pathology reports. They have imaging reports. They know how they're doing. And in, facial nerve care and facial plastic surgery, we don't have as many objective metrics. But I do try to implement the ones we do have into my practice. We have a variety of grading scales for facial function, including the E-FACE, which is a clinician graded scale. and Emotrix, which is actually a computer algorithm that calculates facial asymmetry. And then the FACE instrument, which is a patient-reported quality of life instrument. And so I do my best to get kind of before and after metrics for all patients that I intervene on in all of these domains to make sure that we actually are kind of obtaining objective improvements in facial function. So it's just a little bit of what kind of like an e-face score would look like versus an Emotrix evaluation. These patients can have a lot going on, so I do my best to make sure their care is convenient and accessible. Oftentimes, especially the cancer patients, are seeing multiple providers, radiation oncologists, surgeons. So I try to expedite their care, do reinnervation techniques at the same time. Maybe it's their cancer surgery, or offer them interventions in the clinic to save them a trip to the operating room when possible. But of course, care coordination continues to be a big challenge. These are complicated surgeries, complicated problems. Patients come to me with all different levels of kind of understanding and medical literacy. And so it's really important to work with like a really good team who has the compassion and the ability to communicate with patients and kind of talk them through their care plan. And so I'd love to give a shout out to my clinic staff, including my nurse Monica and my nurse practitioner, because they communicate with these patients every day and make sure that their care is coordinated and that they understand kind of what the plan is. But the paperwork is never ending. I don't think I'm the only one who deals with that. There are issues with insurance and dedicated codes that we're constantly trying to figure out because this is a new and evolving kind of branch of medicine. But I think we are making good progress. I think we're doing good for our patients, and it's just, it's a work in progress. So a few kind of last minute points to wrap up the talk. If I want you to remember as a patient, a few things from what we discussed today, I would say that any new onset facial palsy should prompt an urgent evaluation, ideally in the emergency room. Not all facial paralysis is Bell's palsy, and so it's important to rule out a stroke or another more dangerous etiology of a facial paralysis. Accurate diagnosis is really key. And then, once you've ruled out something dangerous or addressed it, then it's also important to be seen by a facial paralysis specialist, someone who's familiar with some of these treatment options sooner rather than later, because some of these interventions that I've discussed are time sensitive. Even if it's a transient Bell's palsy, I want patients to know that if they should develop synkinesis down the road, and not everyone does, but for the 30% or so who do, they need to know that there are options to treat it. And I think 20 years ago, people were told just be happy you recovered it all. And it wasn't really recognized as a treatable entity, but it absolutely is. And there's a lot we can do to make those symptoms better. We've fortunately made a ton of progress in this field, but challenges still remain. And so we're continuously looking to provide better care for our patients. And I think that's all I have today. So hopefully I didn't go too far over. Thank you guys all for your attention. And again, thank you for the invitation to speak on this topic tonight.
Christina, that was fantastic. Thanks for this. This was great. I learned a lot too. So that's always something good. We have a couple of questions in the audience, and I wrote down some questions too because I have some for you. The first audience question is, while you're performing these nerve transfers, can you talk a little bit about allograft versus patient nerves from elsewhere? And so sural nerve versus using nerve allografts and what your practice looks like.
Absolutely. This is a really kind of hot topic, and I think we need a lot more research and investigation in the area because this is an area of interest for me as well. I would say overall, because I'm largely reconstructing a motor nerve with pretty decent size of the defect, I generally I default to an autograft. So I'll typically borrow a nerve graft from the patient's own tissue. My two favorites, I know you have your favorites. My two favorites are one, the great auricular nerve, which provides sensation to the ear. And the other is this longer sensory nerve of the lower leg called the sural nerve. I don't have a lot of extensive experience using allografts for reconstruction of kind of larger diameter or width of nerve defects. But I think there is potentially a lot of advantage to doing that because these nerves, even though it's well tolerated, they do have side effects. So patients, for example, who have a sural nerve harvested will then kind of have a permanent numbness of the outer portion of their foot, or in the case of the great auricular nerve, numbness of the ear. And oftentimes, especially in cancer patients, these nerves may not even be available. So my understanding is there has been some really interesting preliminary data on using some of these allografts for smaller sensory nerve defects. And so I think they could hold a lot of promise, but a little bit more work needs to be done on the larger motor side of things. And then they really could hold a lot of promise.
That's great. And then the next question's on selective neurectomy. And so when you do these, what about neuroma formation? Do you see neuromas or do anything to do to prevent or protect for neuroma formation in those surgeries?
Good question. So neuromas, for those who aren't familiar, is kind of a traumatic, I guess, scar ball of the end of a cut nerve. Sometimes people can have interpreted neuroma as almost like a painful little bump, and they can associate like sharp shooting pain with that. And traditionally, we do see neuromas in patients who have damage to like a sensory nerve. I've seen that in patients who had actually the great auricular nerve cut, after cancer surgery, and they develop a little neuroma. And when it happens, it's troubling for the patient. It's problematic. I will say, knock on wood, I have never had a issue with neuroma formation after a selective neurectomy. It's just not something that I've come across, and my colleagues who do this procedure also have not reported this as a problem yet. Again, it's still an evolving field. A few things that might contribute to this are the fact that this is, primarily a motor nerve and not a sensory nerve. So again, it's not like these nerve branches are contributing to sensation anyways. So is it possible you do get a little neuroma, but since it's not a sensory nerve, your brain doesn't even register it as existing? I think that's possible. We also, when I snip the nerve, I then kind of bury the cut end of it into the deeper muscles here to kind of protect it and also to keep it from like resprouting and regenerating in a way that I don't want. So it's possible that's protective as well, but I can't tell you exactly why that is, but fortunately that is not a problem I've come across.
Yeah, and I agree. That's exactly how I would have answered that. I think motor nerves are less likely to form neuromas. I think we see that in anterior lateral thigh flap or leg flap reconstruction. We typically have to sacrifice some small branches, but we don't have a lot of problems.
Yeah.
The next question is my question about selective neurectomy. And so you showed a really great video and you're picking some branches. I mean, how do you know how many to pick? And how do you know kind of how many is too many, and what's an average number that you usually kind of go through when you do those segmentations?
Great question. That is literally the heart of this operation, and it's the hardest thing, I think, because anyone can kind of learn how to do the dissection and find the branches. But where you really start to sweat is when do I keep this one or do I, get rid of it? And that's really the art of the denervation. So there have been studies that looked at, tried to differentiate, the really like A+ outcomes from, the more modest outcomes. And some predictors of a more successful outcome are patients who are older, have a viral reactivation etiology for their facial paralysis, and patients who have had paralysis for more than 2 years, and then patients who had 4 or more branches transected during the neurectomy. So, which makes sense. I mean, the more you denervate, the more dramatic result you see. But it's a fine balance because you don't want to over denervate. Fortunately, that does seem to be much less of a problem, but it's still a theoretical concern. So I would say that I, on average, will identify probably between 10 to 12 branches. And I would say on average, I in my practice would transect about 5 to 7 of them. And it tends to follow a certain pattern where these higher branches that do the smile are more likely to stay. The lower branches that pull down on the corner of the mouth are more likely to go. And then this lower lip depression, the marginal branch, is kept. But again, I do tailor it. So patients like the woman I showed who have a lot of like mid-face pull or kind of snarling of the upper lip, I might be more likely to aggressively denervate these higher branches as opposed to someone who's more mild in their synkinesis. And their problem is really just that they're a little tethered in the corner. I might leave all these branches intact and only take some of the small branches down here. So it just depends on each individual patient.
Great. No, that's a great answer. Are there any other questions that we have? We answered the ones that were there, but if anybody else wants to write something in the chat or speak up, we'd be happy to hear from you. Okay. Well, we're always happy to hear from you separately. I think some of our contact info is on there at the University of Pittsburgh. So if you have any questions or concerns, you want to be evaluated by Dr. Yver, we'd be happy to see you. Otherwise, yeah, again, Stephen, I think that's about it. We can call it. We'll give you 7 minutes or 6 minutes back this evening. So we really appreciate it. And any final closing comments there?
I would just like to thank you both. Thank you, Dr. Yver, for an outstanding talk, incredibly informative. Thank you, Dr. Spector, for moderating as well. And we look forward to your talk, which likely will be in May. Just as a final reminder, we will get this on YouTube. Give us a couple days. It just takes a little bit of time to kind of process it, get it uploaded, and we'll let everybody know once it is available. But with that, yeah, I hope everybody has a great evening, and I'll see you at the next webinar. Thank you.
You.
Thanks again.